Good morning, everyone, and welcome to Anchor of Hope. I'm Andrew Brewer. I'll be your host and moderator for today. Before we get started, I do want to remind the group that today's seminar is going to be recorded and posted on YouTube. Thank you for joining us this Saturday morning for Anchor of Hope. We're really hoping that this will be valuable time that we can use to expand not only our psychological knowledge on today's topic, but also to experience hope and healing that comes from learning about Jesus and how spiritual health ties into mental health. We'll begin our topic of Anchor of Hope today on bipolar depression. If you missed previous sessions this year on ADHD, depression, reactive attachment, trauma, effective parenting, and suicide awareness, you can watch them on our YouTube channel, Oak Health Foundation, Anchor of Hope. At this point, I'd like to introduce Dr. Alyssa Lucas, who has done many sessions with us. And afterwards, we will have a Q&A session with our panel of clinicians that are present. During the seminar, please feel free to chat me. You can see my name, Andrew Brewer, and then moderator/OHF. Send your questions directly to me at any time. Before we begin, let me open us up with a word of prayer. Dear God, thank you for this opportunity to discuss oftentimes misunderstood and challenging struggle that people are going through with bipolar disorder. I hope that we can open our hearts and minds and learn how we can just understand the peace that you can give to those who are struggling with this, but also help us use whatever grace you're giving us so that we can be more understanding for those who are struggling, so that we can be resources for them. I pray for Dr. Alyssa as she leads what's going to be, I imagine, an amazing conversation today. Please speak through her and just bring more individuals and members of our communities closer to you so that they can just benefit from the freedom and peace that you provide. In Jesus' name we pray. Amen. Dr. Alyssa, please take it away.
All right. Welcome, everyone. Before I share my screen, I just wanted to say, but before the presentation, we were in a word of prayer, and Dr. Esther mentioned something of how important this topic is, and it is very distressing and a lot of stigma attached. And one of the things that I really want to hit home today is how Jesus can bring this hope to such a difficult lifelong challenge. So I don't want to, I found myself getting very clinical as I was creating this presentation. And I also want to frame it from a perspective of hope, because Jesus does bring that for us. So I will share my screen now. So today we are going to be talking about bipolar disorder. And so here's just a quick overview of some of the things that we're going to be learning, talking about, discussing. So symptoms, rates, and etiology of bipolar, impairments, and some of the stigmas associated, comorbidities, and suicidality, which is a very, very, very big part of this disorder, bipolar in the brain, and treatment. And then most importantly, God's love overpowers all. So we will go ahead and get going. So what is bipolar? So previously known as manic depression, renamed in the 80s through the DSM-3. So one of the benefits of this shift is that it recognizes that the illness isn't as black and white as we once thought. We kind of figured, bipolar was this or that. And now we're recognizing that it tends to be more on a spectrum, and it's not as clear cut as previously thought. Okay, so we have 4 types of bipolar in the DSM-5. So bipolar 1, which is what we sort of typically think of when we hear the word bipolar. So manic or mixed episodes lasting at least 1 week. the manic symptoms are severe enough for hospitalization. And so these are pretty intense symptoms. And also what's interesting with bipolar 1 is approximately 10% of the people don't experience depressive episodes at all. So just because we don't experience some of the depressive episodes of bipolar doesn't mean we don't meet criteria. We definitely want to address those manic episodes. And then bipolar 2, which is often thought of as a softer bipolar, which is not the case. It is not soft and it is not lesser. It is just different. So instead of full manic episodes, people that struggle with bipolar 2 experience hypomania. So it's persistent, abnormally elevated or irritable mood accompanied by unusually increased activity for most of the day, over at least 4 days, as well as depressive episodes. And then cyclothymia is also sort of like a subclinical experience. So you can kind of look into that further if you'd like. And then a bipolar disorder unspecified. So it doesn't necessarily meet the criteria of bipolar, but the symptoms are clearly out of character and are really causing significant impairments in somebody's life. Okay, so bipolar 1 versus bipolar 2, I just mentioned this a little bit, but it is not less severe or less debilitating. It just is different. The hypomania is experienced differently than manic episodes. So individuals with bipolar 1 were symptomatic 47% of the time, with depressive weeks outnumbering manic and hypomanic episodes. And with bipolar 2, they were symptomatic for 54% of the time. So just because it is not full-blown manic episodes does not mean they are experiencing less symptoms. So again, I want to really talk about this, is the difference between mania and hypomania. So both manic and hypomanic episodes require the presence of at least 3 of the following symptoms during the disturbance. So inflated self-esteem or grandiosity, decreased need for sleep, increased talkativeness or pressured speech, racing thoughts or flight of ideas, distractibility, increase in goal-directed activity or psychomotor agitation, excessive involvement in activities that have a high potential for painful consequences. So it's actually kind of interesting because other than the last one, all of these things, like indistractability, some of these things sound really great. I want to have a flight of ideas. I want to have an increase in goal-directed activity. And we'll talk about that a little bit later of why some people struggle so much with this, because some of those things are really helpful in today's society, where we're just on the go. So although back to mania and hypomania, although the symptoms are described in the same manner, it's the change in functioning that is something we really want to hit home. So hypomania leads to less impairment than mania. Like I mentioned, a lot of times mania leads to hospitalization because individuals are experiencing something so intensely that they have a difficult time controlling their emotions, their actions, things like that. And oftentimes manic episodes also have an element of psychosis to them. Some people, not everybody, but some people experience psychotic episodes during a manic episode, which then sort of like leads to the tendency maybe to forget a little bit about what happened, or forget the effects that a manic episode could have. And some of the high potential for painful consequences could be during a manic episode. Spending hundreds of thousands of dollars on a credit card, or racking up credit card bills, going shopping, doing the things really impulsively, or having unprotected sex and just going really impulsively, and having a hard time thinking about what your actions are and the consequences. Again, hypomania is not as intense as that. It tends to be less likely that it would lead to some sort of hospitalization or as not having as severe effects on somebody. And like I mentioned a second ago, this is a double-edged sword. People often enjoy experiencing feeling happy and energetic, especially, and this is really important, especially if they spend a lot of time in a depressive episode. If I am feeling depressed for most of my life and can experience energy and excitement, I kind of want to stay there. And so that we'll talk a little bit about that when we talk about treatment, which is sometimes what makes it difficult for people struggling with bipolar to adhere to their treatment regimen, which typically involves medication. So sometimes that compliance can be really difficult. So people often feel more productive and feel more creative during a high episode. And this is, again, a lot of people in the arts are like, my brain can only go there if I'm at that flying high. And so it feels good. So hypomanic episodes can potentially turn into full-blown mania if left untreated. And again, if we also are not managing hypomania or mania, that can definitely lead to a crash into depression, especially when we realize, the effects of behavior from a manic or hypomanic episode. And at its extreme, mania can be dangerous and destructive. It, again, I think one of the most important things to remember is sometimes people struggling with mania it is hard to remember exactly what was happening during that episode because our brains are not functioning in the same way they would as if we were in a very stable cognitive state. Okay. And definitely, so some of the significant impairments that we can see can be problems with friends, family members, community, and the law. The law is a big one because sometimes it's hard to say, I don't remember doing these types of things, or I wasn't in my right frame of mind when I did this. We are still held accountable for our actions. And so I thought this was actually really interesting for clinicians and people working with individuals that struggle with bipolar, is we want to really help people manage these episodes, because the more episodes an individual have, the bigger possibility it is for cognitive decline, which as they get older, which increases the risk for dementia. So just because you are diagnosed with something like bipolar 1 or bipolar 2 does not mean you will have dementia. It just means that you're at a greater risk for developing some of those symptoms. And as clinicians and family members that are supporting people that are struggling with bipolar, this is really important, so we can kind of have the earliest intervention as possible. So depressive episodes, we've talked about this before in Anchor of Hope. And so these are some of the symptoms that somebody with bipolar could experience when they're in a depressive episode. So typically, we have anyone that's struggling with bipolar has periods of mania or hypomania, which is what I just described, followed by, or sort of, it could happen at the same time, but we'll get to that in a second. And then experiencing depressive episodes. So it's the highs and the lows. That's why we, have labeled it bipolar. So high and low. So a person may be experiencing the depressive phase of bipolar disorder if some of these symptoms are present for at least 2 weeks. So depressed mood, loss of interest or pleasure, weight gain or loss, difficulty sleeping, apathy, agitation, loss of energy, feelings of worthlessness and guilt, inability to concentrate, and thoughts of suicide. And we will get to thoughts of suicide again, because that is very, very important. I know we spoke about it last month during Suicide Awareness Month, and I want to bring it up in this discussion about bipolar because it is very, very, very important. And a mixed episode. We can experience both of these things at the same time, which would be a mixed episode. So it occurs in 10 to 30% of cases. And this tends to be indicative of a more severe and disabling course. Does not mean it's not treatable. It is absolutely something that we can treat with through therapy, medication. We'll get to the treatment in a second, but I want to also make sure that everybody is aware that this is something that we can work with, and is absolutely treatable. So we, again, mixed episodes are very important because we want people to be aware that there's a heightened risk of suicide in this state. Research. We're going to talk a little bit about research. I'll go through some of this pretty quickly. And again, if you guys have questions about this stuff, we can talk about it in our Q&A session. So risk of recurrence increases with the number of previous episodes. So some of this sounds a little wordy. So let me explain. So the more episodes we have, the more severe the symptoms might become. And so we will, again, this is so important of why we want to reach out for help and support and treatment to be able to manage these things before they feel like they're too much for somebody to handle. So the kindling hypothesis is typically like there's a major life event, a major stressor that so somebody might have a predisposition for bipolar based on genetics or hereditary challenges. And let's say somebody experiences a very big stressor in their life, then it tends to trigger that initial episode, typically like a manic episode or hypomanic, or it could be depressive episode also that might shift eventually. But it doesn't necessarily mean that we're only going to experience episodes when a stressor occurs. So the more episodes we have, the more they may start to occur all by themselves without a specific trigger. And this is also important because we want to differentiate between something like PTSD or post-traumatic stress disorder and bipolar. So we want to sort of understand where the challenge is stemming from to be able to have a proper diagnosis. So it's estimated that 1% of the population has bipolar disorder 1, 1.1 bipolar disorder 2, and 2.4% sub-threshold. So don't necessarily meet criteria, but it still is a very big challenge for them. And it occurs equally between men and women, although women tend to be diagnosed with rapid cycling more often than men. And rapid cycling is shifting between depressive episodes and manic or hypomanic episodes more quickly. So average age of onset, typically it's the late teens. So between 50 and 66% are experiencing the onset before age 19. So earlier age of onset is typically associated with a more challenging course of the illness. It does not mean it's not treatable. It means it is really important for us to seek help and support to manage the symptoms. And again, some of these really big challenges with people struggling with bipolar is it's hard to keep a job, right? So you're having lower wages, unemployment, you're not showing up to work, right? So these are really big, again, financial struggles, right? Relying on workman's compensation, you're more typical. It's typical that you might utilize that more often. Lower levels of educational attainment. It's hard to focus in school when your emotions feel unmanageable. Higher arrest rates, again, that's associated with the manic episodes, right? If we're in a manic state, we're more likely to do something unlawful that will get us arrested or hospitalized. And a big piece of bipolar disorder is the rates of substance abuse and dependence, because sometimes substances will mellow people out a little bit or help them forget about the emotional turmoil that they're experiencing. So we really want to address all of these challenges, not just what we consider like mood swings. We want to see people struggling with bipolar as a big picture. And increased rates of divorce. Again, like I mentioned before, there's a lot of challenges that come up again with work, family, which is why the rates of divorce are increased, because sometimes people that struggle with bipolar have a really hard time connecting or engaging with a partner in a healthy way. It doesn't mean it's not possible. It just means that we have to work a little bit harder to be able to have those healthy attachments and create that loving space. Big one, mental illness and suicide. So I know, again, we talked about this last month in Anchor of Hope. And I thought this was very interesting. The research is showing that the highest rates of death by suicide, not depression, which is very important, obviously, but I was very surprised at this. Of psychotic disorders, yes, makes sense, but bipolar disorder is number 2 at 6 to 7% of individuals struggling with bipolar disorder that are diagnosed will experience death by suicide. So important for us as clinicians to understand this and to educate our clients, our families, that this is a real issue and something that we really need to be paying a lot of close attention to and approaching with care and love. And number 3, substance use disorders. Number 4, depression, sleep disorder, and anxiety. So that's sort of the order of diagnoses. And not to mention, somebody could experience 1, 2, 3, 4, 5, or 6 of these. So it's and the more challenges somebody's having, the more aware we want to be of their thoughts of self-harm, thoughts of suicide, all those types of things. So we can do what we can to support somebody that we care about. Treatment. This is wonderful. We do have treatment for bipolar disorder. So big one. Psychoeducation. We want people to be aware of the struggles, be aware of the challenges, and start to reduce that stigma. How many times, and I'm sure we'll get to this in the Q&A, how many times has me, I'm guessing a lot of people that are watching this or joining today have said, oh my gosh, I've just felt so bipolar today. Well, let's talk about that. What does that actually mean? We use it as a way to say, like, I'm feeling up and down. But that's a very intense statement that we want to not take lightly, because some people are really struggling with this, and that makes sort of invalidates their experience. So I want a lot of us to be aware of what comes out of our mouth when we talk about our challenges. So psychoeducation, again, really important for the individual, the client, as well as the family and anyone that is interacting with the person struggling in any way. And then evidence-based practices for that. CBT, cognitive behavioral therapy, very important. DBT, dialectical behavior therapy. And it is interesting because DBT was originally for borderline personality disorder. But if you think about it, there are a lot of ways that borderline personality disorder and bipolar overlap. It is not the same. It is not the same. Sometimes that can get confusing and can be misdiagnosed. But the skills for DBT, which is to help with emotional dysregulation, that works wonderful for people that are struggling with bipolar. And again, if anyone wants to know more about that, we can chat about it later. Family focused treatment. We definitely need support for our people that are struggling with bipolar. A strong support system, not a support system that's judgmental and like, come on, just like figure it out, right? We really want the family to be informed and to help support their loved one with grace and help them create peace in their life. So a big one, stress and lifestyle management. The more we can reduce stress in somebody that's experiencing bipolar, the more they're going to be able to manage their emotions. And again, really important addressing comorbid disorders, especially if there's some sort of substance use, because that can really shift the chemicals in our brain that then in turn can really affect our behavior. Big one. Medication, which is the cornerstone of treatment for bipolar. Yes, DBT, CBT, behavioral things can be really helpful, obviously very, very helpful. And sometimes the brain needs some shift in neurotransmitters and brain chemistry to be able to effectively use the skills taught in CBT and DBT. So shifting gears a little bit, I was thinking about the way that we identify or define our identity. And a lot of times I am blank, right? Like I am depressed, I am anxious, right? We tend to like stick to that. I am bipolar. I like these things are me. And what if we were able to shift that thought to I am a beloved child of God. I am worthy of treatment. I am shifting this to something that creates more sense of like belonging and love, because it's exactly what Jesus has intended for us. And again, I'm not sure if you guys had seen my discussion about trauma, but sometimes we think, why is this happening? And we tend to think about that with mental illness, right? Like, why are these symptoms happening? Why is this happening to me? And if we can shift to God's got this, and giving us that hope of healing. So what are the possibilities if we do shift that thought? Like the possibilities are endless. If we shift from I am bipolar to I am a beloved child of God, like, whoa, that's cool. I get excited about that. So the possibilities, just 3 that like popped up into my head. Healing, right? If I adopt the thought I am a beloved child of God, I will experience healing. And if I'm a beloved child of God, I might be compliant with my treatment. I might go to therapy every week. I might take my medication properly because I deserve that. I am worthy of that because God says so. And again, like in the other direction, if I sit from a place of I am bipolar, I can't help it, there's nothing I can do about it, we might not adhere to our treatment in the same way as if we really adopt the view or identity as I'm a beloved child of God. And again, if we are adhering to our treatment, we are in a much clearer headspace to see God's truth and experience his love of we are beloved children of God and worthy of connection, and happiness and healing. If we believe we are worthy of healing, we will be in more of a space to actually experience that healing and want to do that. And again, easy question, why? And again, this is such an important topic, because again, suffering, right? Why am I suffering? If God is almighty and good, why am I suffering? And it's, again, going back to that trauma talk, go check that out if you haven't seen it yet. We have to stand firm and hold faith. So again, I love this verse, Romans 8:38-39. For I am convinced that neither death nor life, neither angels nor demons, neither the present nor the future, nor any powers, neither height or depth, nor anything else in all creation will be able to separate us from the love of God that is in Jesus Christ our Lord. Not even this debilitating challenge that we call bipolar, that is not going to separate us from God's love. And like I mentioned a second ago, God is in favor of treatment. He wants us to take care of ourselves, because again, if we adopt the identity, I am a beloved child of God, of course we're going to seek treatment and healing and love and connection. And again, that treatment allows for the clarity of our mind, so things aren't so muddled to where we don't see God's love for us. Love this. You are priceless, fearfully and wonderfully made. God shaped and molded you in your mother's womb. God created you in his own image. You were created, redeemed, and are deeply loved and valued by God. Love that. So we are at the end. So I just wanted to say thank you, everybody, for coming by, and we'll shift to question and answer time.
Thank you, Dr. Alyssa. And like you said, it's now time for our Q&A and group discussion. So in addition to Dr. Alyssa today, we will also have Dr. Esther Park, Dr. Meejan Park. This will be our panel for the day. Again, please type your questions directly to me, Andrew Brewer, and it has moderator/OHF in the next to my name. But my first question is, I'm kind of curious that we've got here, but why is there such a stigma attached with bipolar disorder?
I love this question. And I think I'll just start off. I'm sure that everybody else wants to chime in about this. I think because the symptoms and impairments are so intense that they are more visible to people, which then people naturally start to judge, and then we are creating stigma, right? So I think the intensity of the symptoms tend to lead to judgment by others.
Yeah, I piggyback on that. It's very erratic for some of the, especially type 1, even type 2. So the general population, friends and family, they get totally weirded out if the one who's suffering from this disorder is very, very happy and excited and energetic and multitasking, as if it's their personality, and then suddenly switches to and swings. That's why we call them mood swings, to a depressive disorder or episode, and then they're in bed all the time, they're melancholic. So those who are viewing this are like, what are you doing? You know, why are you like that? And so that typically in history, the erratic switches can cause people to generally like, oh, bipolar, and then over time it became very stigmatized.
Mhm. And also, I don't think it's only bipolar disorder, but any mental illness historically, not only culturally, socially stigmatized, but also religiously stigmatized.
Mhm.
If we are not within the quote unquote norm, long time ago, before all this mental health and science and studies is proved, that they consider that as a demon possessed. So again, that could be the reason why I think is strongly impacted on the stigma on any mental illness, not only bipolar.
And it's very unfair and unfortunate when it is a biochemical and neuropsychiatric struggle, and it's visibly behavioral, right? Like on the outset, it's manifested with behaviors and thought processes and feelings. People didn't realize of how neurochemicals, serotonin, dopamine, acetylcholine, like GABA, like there's all of these that influence this. And but long ago, before all of the research confirmed all of that, but it's kind of late now, right? This whole next generation is still basing on what the previous generation has believed it. So Oak Hill Foundation, one of our main goals is to bring that awareness and to not only reduce the stigma, but try to get rid of it because it's erroneous.
Yeah. And also in our Christian circle, right, believers, it often measure with our level of faith. So that's another reason why it's stigmatized very strongly in church rather than seek for help.
All right, thank you. Next question. Do all bipolar patients need medication? When do clinicians recommend medication to their clients?
Mhm. I guess I'll answer that as a prescriber. First, we take very good, how should I say this? We evaluate as carefully as possible to make sure the diagnosis of bipolar disorder is confirmed. Just because someone comes to my session and says, I have mood swings, I have bipolar, I don't necessarily just say, okay, and then give a mood stabilizer medication. I evaluate very carefully, making sure that there are no other causes that can mimic the condition of bipolar disorder. So with that said, if I came to the conclusion of the diagnosis of bipolar disorder, it is not substance induced, it is not a medical problem induced condition, then I have to share with the client, especially bipolar type 1, especially you cannot go without treatment because we don't know when the next manic episode and when the next depressive episode, that's why it's called bi, because of the two poles, right? We don't know when those next episodes will occur, but when they do, it will be very dangerous to not have been treated. And the suicide rate is so high, at least even 15% of untreated bipolar will end up with suicide deaths. That's not even including attempts. So we share that this is a very clinical, medical, psychiatric issue and begin treatment. And I try not to announce during my session, and this is for life. You're gonna take it forever. I mean, that is very discouraging. But to answer the question, the answer is yes. I anticipate a long-term care and treatment, but along the way, when somebody who is properly treated, they are not only functioning, they thrive in life. They reach their greatest potential. And, we don't give all the credit to the medication, but that is definitely the platform to begin that process. Without it, it's as if like you're going to leave your broken leg broken. You don't even start going through the healing process, then it's going to stay broken forever. So I use that analogy a lot.
Any other thoughts from our other two panel members?
I definitely agree with that. And sometimes, yes, the medication obviously is extremely an important piece of this. And sometimes I think people are like, oh my gosh, okay, so I have to do this my whole life. But therapy looks different throughout the span of our lives with bipolar disorder. It, sometimes things might be really intense, so we need a lot more CBT or DBT, specific types of treatment, but it doesn't always have to be so intense. So we can create healing and success through treatment and not necessarily have to be so intense with the treatment always, if that makes sense.
Awesome, thank you. I think I have two questions here that can kind of be merged into one. I think the first side of the question is, how can family members help a loved one with bipolar disorder? But then on the flip side, there's another question for family members who are living with somebody with bipolar disorder. What are some things that they need to keep in mind so that they can also maintain their own mental health and ensure that they are staying healthy as well, so that they can be better support? I hope that's not too much all at once.
Yeah, maybe we could tackle them one by one. So the first one is, how can a family member be of support?
Mm-hmm.
Okay, that's a very good question.
I think and initially starting out with our own biases and our own thoughts that we've created about whether it's mental health or bipolar in general, right? So understanding what am I automatically assuming about my loved one? And so really working through and being self-reflective in that way of how am I actually experiencing this person? What am I feeling? Because also our family members of people struggling with bipolar, their feelings are valid also. It might be we had just mentioned a little bit ago, it's really hard to see somebody you love and care about with those ups and downs. Where 1 minute they're really go get them, got life, handled, and then the next day feeling really depressed and not able to get out of bed. So understanding our own thoughts and biases about that, as well as our own sadness and frustration with somebody's challenges. So I think that self-reflection piece is huge.
Yes, one of the initial reactions that I get when I tell a client that they're diagnosed bipolar, sometimes it's the family member who's in denial and would say, no, oh, no, you don't have that. You don't have that. And it comes out of just anxiety and out of fear and out of just rejection of a label, for example. And so for this question, I would say, even if it's difficult to believe, you don't have to, but to support the family member who is the client by maybe offering to go to the appointment with them, and to start asking questions. What is bipolar? How did you come to that diagnosis? How do you really know you? How do you really know that my family member has that? What's the prognosis? What's the treatment? And going to appointments together or offering to do that is very supportive for the client. Right now, I feel that way because parents must come with their child and adolescent clients. So I already know that support feeling. But when a spouse or a significant other or a parent comes with, or even the child of the client comes with them to the appointments, the client feels supported. And after that information has been received, can go home and discuss together. So what did you think what did you think about what the doctor said? You know, do you believe it? Do you want treatment? And not be a negative influence, but not be pushy either. I know there are a lot of parents, you better take your meds. And then they do a follow-up. Did you take your meds today? Right? That's not as it's supportive, but it won't feel supportive, right? So, so that's how I look at the initial time of how a family member can support.
Mhm. Dr. Lisa mentioned during her presentation today, psychoeducation is a very, very important piece. And then some patients and some family members, they don't even know what that is. So getting diagnosis, what it is, what caused our loved ones or family members having that much of a difficulties is very important. But regardless, of course, any sicknesses will be very challenging as a loved one to watch, right? But bipolar is also a very, very challenging conditions for family members will experience extreme pain as well. Spouse, parents, even their children, right? So first is the psychoeducation is very important. So it is not about them that they don't want to do it. It is a medical condition that they cannot do it. And sometimes they want to push themselves up and wanted to do it, but they can't. It's not that they don't want to. It is not of the willingness of the doing it, right? It's a conditions that is something that they can't not do it. So we have to understand that piece so that while our loved ones are getting treatments, family members, spouse, and children, or even parents also needed to get some treatments as well. So they understand, and then they needed to have their support, the support that they cannot get from their the loved ones sometimes will be, I think, one of the important factors that how we can support to the loved ones who are suffering. So I have to get well as well. Right? And also knowing that it is not their willingness or their will or their choices. It is a condition that they can't.
And on the flip side of that too, I think also family members might tend to shift to the other extreme of like, oh, my child or my spouse or my loved one can't do it, so I'm going to do everything for them, right? So I think there's a very fine line between enabling and supporting that every family that is challenged with bipolar disorder, affected by bipolar disorder, has to kind of find their groove, right? Their balance, what works for their family. Because, you know, every individual needs a different level of support. So I think that's also really helpful to sort of like identify and work through. And that's why I think family therapy is such an important part of this condition, to understand how to help this person be successful in life.
I came across a case where I needed to do much counseling for the father of the client. And I'm not sure if the client is yet diagnosed with bipolar disorder, but along with that, heavy use of cannabis, which is marijuana. And he's just doesn't know what to do on convincing his son to try to get treatment. So with bipolar disorder, as Dr. Lissa mentioned, the comorbidity of substance use disorder, especially these days, is very, very easy to use cannabis. Although for that day, it relaxes them, and for that day, they can forget about their worries. Cumulatively and chronic use, it worsens the condition. significantly. And so the psychoeducation to family is to help them up to where they can really assist and nudge and prompt their loved one about treatment, and then also where to draw that line and that boundary. Because if you're giving free rent and free food and also allowing them to use in the house, that kind of enabling behavior can keep that going, that behavior going. So the job of the clinician is to also help the family members for that. Also to share with them, with the family member who's struggling, hey, if you keep stopping your meds, I'm going to have to tell your doctor, because that's so dangerous. Out of my love for you, I have to tell the doctor you're using drugs, because with erratic treatment for this very erratic disorder increases the risk for suicidality and for future complications.
Awesome. I think you all kind of transitioned into that second half of the question, but just as a reminder, talking about, what are the ways, how do the family members, maintain their own mental health? And then I think, speaking of family members, we've had an additional question is, in addition to their mental health, how do you better become more educated so you're not misinformed, so that you can see the reason behind it? What are resources you may seek as a family member of someone who is working through the challenge of bipolar disorder?
I think a big one is understanding where you're getting your information, right? Am I just Googling and looking at the first thing that pops up? Or am I being really thoughtful? Am I going on the NAMI website, National Alliance on Mental Illness, right? Like, am I really in understanding things that are up to date and like legit resources? So I think a great way of doing that is asking your mental health provider, right? Like, where can I go? How can I join, a support group for if I have a loved one that's experiencing bipolar? If I have bipolar, where can I go to like learn more? How can I educate myself in the best way possible? So I think that the working with your mental health provider is really important, and understanding where you're getting your information.
I also want to encourage family members, especially parents, that they are going to do their best, but sometimes they subconsciously hold on to this responsibility of saving their child, or I am going to be responsible for not only the treatment, but for recovery and healing. And that's a burden that shouldn't be taken on. We need to help our family members. We should be supportive. We should do our best to help them, come to the water, right? But then we cannot force them to drink it, right? And there is a blurry line of like where that is. But if we take on that kind of responsibility, suddenly like we're taking on the role of God, right? So for those who have faith regarding this, that they ask God for guidance. How can I show them your love, your acceptance, your unconditional forgiveness, and yet to help them understand and create insight about their condition and their need for treatment and the potential of what that healing could look like. But at the same time, the humility of like, but God, you have to ultimately do it. That you have to put that insight. You have to convince them that they need this and that it's very worth it to get treatment and so on and so forth. So I just, have to remind myself that, because as a prescriber, and prescriber is the first treatment of choice of treating bipolar disorder, when my clients come in, I have a huge sense of responsibility. I've got to pick the right medication, the right dose without side effects, and make sure they're taking it all the time, right? As if their recovery or their relapse, is my responsibility.
In any conditions, right? So any diagnosis has degrees, the levels of differences. So the reason why it is so important for family to participate for the treatments, not only the medications, but also therapy or the family sessions, because our loved one, our spouse, the condition is a bipolar, but the depth of especially when they're hit the depressive episode, the negative thoughts, negative beliefs, this is the reason why CBT works in here. And all that is from their own experience and past trauma and past negative experiences with their own childhood, right? So if we don't understand our loved ones and our patients' past and their experience in life and their family, we're just looking at the surface again. It's just the bipolar. Just knowing about or criteria about the bipolar will not going to help a support for the patient, because every individual comes with the layers of that symptom. So for example, when they're in a manic, not everyone is just spending all the money. Not everyone is excessive sex activities. It's just a different way of coming out of it. But if we understand where is it coming from about their life stories, we can understand and help better. So this is a reason why it's so, so important having the family session together with them, couples therapy with the spouse, one another, be there and listen to them when they're in the state. So then we will understand better and help in a more effective way for our loved one.
Oh, yes. Another area is stress, right? So Dr. Alyssa talked about how stress can induce another episode or worsen a current episode. So sometimes it's stressful in our homes, right? In our family and relationships. So if there are family members dedicated to really support, to manage their own stress, and also to be a support of helping to moderate the stress levels of the one who is going through an episode.
Thank you. I think the biggest thing I learned is, Dr. Alyssa, you're telling me that WebMD and Google will not solve all my mental and physical ailments. Dr. Meechin, you talked a little bit about different levels of the condition, which I think is a good segue into another question we've got. If one has bipolar disorder type 2 and the mania is not so bad, why is the mood stabilizer needed? Why can't an antidepressant just be taken as quote unquote needed by how I feel?
I really loved how Dr. Alyssa clarified that the view of bipolar type 2 is a little softer. And technically it's not softer because it's just shorter number of days. The actual criteria of the manic episode for bipolar type 2 is 4 days, not the full 7+ days. But the number of symptoms of the manic episode is equivalent for those 4 versus 7, right? And the level of distance of the manic level, or the height of that energy and activity, down to the depressive episode is the same distance. So I guess I'm going to just say in layman's terms, the fall is the same amount of fall. The pain when you hit that rock bottom for the depressive pole is going to hurt just as much. Not only that, bipolar type 2, my experience with it, that the depressive episode lasts many, many weeks, sometimes for months. And it's difficult to bring that up. Just in research, though, to answer this question, is ineffective to just do antidepressant. and has to be with a mood stabilizer first, but oftentimes I do have to add back the antidepressant medication. Just doing the antidepressant medication, such as serotonin reuptake inhibitors, creates a risk of more cycling of manic and depression and manic depression. So because of that research that came out, we always educate clients. I know you're not feeling manic right now, but your history is bipolar type 2. We have to utilize a mood stabilizer and then re-add back safely the antidepressant. That is the only way to keep both the elevated pole and the depressed pole as close to each other as possible. I hope I'm making sense.
And to like, again, add to that is, I think this is one of the biggest struggles of people that are challenged with bipolar is they don't necessarily want to take their mood stabilizer when they're feeling real good, right? Like, I want to feel good. I want to feel productive. I want to feel that again, I think is why, Dr. Esther, correct me if I'm wrong, but this is one of the like most difficult conditions and disorders to have medication compliance, because it feels real good sometimes. And so I just think, again, like kind of going back to that family question is like helping support. Even though sometimes you might want to feel those highs, is it worth, like we want to encourage them to be more stable rather than experiencing the really, really, really high highs, because then what happens? Like,
I share with my clients, and I validate that, and I empathize. It sounds really good. It must feel really good. But I share with them that it's artificial, that it's not them feeling that way. The chemical imbalance of a manic episode at that time is making them feel that way. And it's not sustainable. Not only is not sustainable, it is a weird trick to the mind that can lead to a suicidal moment. It is very dangerous to be at that kind of height, almost elated, sometimes ecstatic, and then the crash after that, right? So it's not a true ecstasy or a true, I guess, happiness. It's not true happiness, right? And if the person is open to an integrative message, then I start sharing about what that true happiness is and where it's coming from. And it's not always a feeling to rely on, but a contentment. And I ask them, like, I feel that you wish to keep that feeling because most of your days are so discontented. Most of your all other days are so unhappy. You're living in that pole down here so much, so long, that when you get to that pole, the elevated pole, it's like, this is how it should be, right? And then I kind of educate them. You've been suffering so long down here that of course you would crave that. Substance use addiction, that's like a similar kind of situation. So so I kind of explain what's going on chemically and how it's not sustainable, and how we can help them come to their baseline, true baseline, without that dip anymore. And if they don't come down to that dip with a depressive episode anymore, then they won't crave up here either.
So wanted to emphasize one more time, this is a medical condition. It's not a behavior issues. It's not about the choice. It is a medical condition. We really needed to understand and embrace that it is a medical condition. So once we are diagnosing any of our patients with a bipolar, either 1 or 2, or any types, we see that this is a more of a brain chemical imbalance issues. So how brain works is simply firing neurotransmitter is released and wiring it. Why consistent medication every day, either I'm feeling good or not, is so important, because the firing, it comes with what we do. Right, but if we are not taking it, if one day it's just a manic, what we do is shooting it more of a fire and then wiring it a different way. And then our brain now getting into the memory sections, it will remember that. Right, and then going back and then going to the depressed episode. Now, that firing, that what we needed to do, right, is not happening again. So it's an inconsistency of the brain activities is creating more of a difficulties when we wanted it to get better or get treatments. So once we know that it is a medical condition, it is diagnosed, then daily and checking with the doctors, checking with the, that therapy and whatever the possible treatments. So making the consistency so that the fire in our brain with what we do, with the lifestyle that we have, and the message that we're listening from our loved one, that how much we love them, and the love of Jesus and how much we love them, so it can fire and wire together. So if, like what Dr. Esther said, the gaps between the manic and depressed, if we get closer and closer, the things that what we can do to create a satisfaction of something that we can do will be increase and improve on that, right? So that I love the, Dr. Elisa's quoted as a cornerstone of this treatment. So it has to be there so that we can create it, that consistency and stability so that we can build and establish the more the quality of a life that what we want. So it is a medical condition. It is not about the choice of doing it and not doing it.
Even though medication management is the cornerstone, the combination treatment of psychotherapy and medication truly has proven to help the recovery to be quicker, more maintained, and sustained. So whenever somebody says, oh, I just have to take my meds, but they don't realize the support and the cognitive training that they can get during psychotherapy is so important. So I just want to emphasize it's a combination treatment would be not only cornerstone, but the best.
All right, I know we're talking about the medical side, and I think that's very important, but we would not be Anchor of Hope if we didn't think about how spiritually we need to address these things. And I think one of the first questions we've got here is, why is there a struggle in terms of finding a church community to supporting those who have bipolar disorder? What do you think the challenge is there?
I think it's awareness, the lack of psychoeducation, and we're saying that word a lot and we didn't define it. So I'm going to just say the psychoeducation, like what is that? We say that a lot in our offices, so we apologize if we're bringing lingo and jargon that we don't define first. It's education about the topics of psychology and psychiatry and everything in between like that. So we just kind of lump it together and say psychoeducation. So it's starting now for sure, more than ever before, bringing in discussion and definitions and how much of a medical nature psychiatric disorders are into the churches, but we still have a little ways to go. And so that's why if there's a lot of ignorance can produce stigma and bias, discrimination, and those kind of behaviors. So to me, that's what explains that in the first place, if people don't know and they formulate their own opinions, then they behave according to those opinions.
And I also think too, if we're not understanding what's driving somebody that's struggling with bipolar, it's very easy to judge and like some of the behaviors, oh, that's a sin, right? And so I think it becomes
Mhm.
I think that contributes definitely of just an unlawful behavior or something that maybe, oh, I'm a quote unquote good Christian, I would never do something like that, right? I think we start to have some of those thoughts about our fellow humans that are struggling with bipolar.
Yes, you reminding me of the DSM criteria of how those things could happen, right? And the results could be substance use and arrests. What else did you talk about? Like increased promiscuity, and all during a manic episode, right? And then the church family finds out, oh, they don't realize that that was from the episode, right? And then the client can feel like, oh, I can't go back. I can't go back. So we can talk all day about the fundamental struggle of general church in general about judging people based on behavior instead of based on that this is a spiritual hospital. We all need to be here, right? That's a discussion for another. Does that answer the question, Andrew?
I think so. I guess the next thing is whether it's somebody who is struggling with bipolar disorder or a member of the congregation who is passionate about this, how would you recommend, if you really you're injected in this community, how do you recommend going about speaking to whether it's leadership or individuals to help get them to open up their minds and their hearts to this challenge? Because obviously, even if we understand why the churches are struggling, that doesn't fix the problem if you can't seek out that spiritual healing. How do you, how can we give that, what would you recommend a potential, whether it's the individual struggling with bipolar disorder or families or members of the congregation, how can they ensure that the place becomes a better community for these individuals?
So I will bring in psychoeducation, right? But also the psycho-spiritual education to, for example, church leaders or the congregation. And I would use what Dr. Alyssa said earlier, okay? And I wrote it down because I was so encouraged by it, about the why is this happening, right? Immediately, church leaders or members can answer that question. Why is it happening? Why did they just do that? And they quickly can answer that question. Oh, well, they're a sinner, right? They have an addiction. They have no control over themselves. Their faith must not help them be filled by the Spirit. And Dr. Liz talked about identity, right? So instead of labeling, oh, you're a drug addict, you're a thief, you're a criminal, you're crazy, right? I know subconsciously people say that in their minds, but to realize the individual and all the church members, that who they are, right? That they're not what they have or what they show, and that everyone is a human being in the image of God. Dr. Liz's final slide was talking about how we're created in the image of God. So I would start off with that, actually, if I were to give a psycho-spiritual education to churches.
No, I agree. This is the reason why we do continuously on this seminar every month with the topics. The believers are not judging themselves or shameful about the things that what they do, but knowing and believing that who they are in Christ. So oftentimes at church or even in the family or in our social circle, we're asking question with the why. The why is sometimes it's a dangerous questions, right? So then instead of a why, in this case, in church community, in our the community circle, that has to start with what makes them, right? What are they going through? So if we have this curiosity and also interested in them, then our approach, either they are bipolar or not, our approach will be more of listening to them and wanted to get to know them. If we say why, then we'll just roll our eyes, right? And judging according to their behavior. Either we're a believer or not. I think our community, if our family members and friends that have to have their heart, that what makes them going through a certain challenges in life.
Thank you. I think we probably have time for, I think this might be our last question. We'll see. We're getting close to that time, but I do want to bring this question up at the end, because I think as we wrap this conversation up, it'll be nice to think about something encouraging and hopeful. And so when you hear a bipolar diagnosis, that's there's permanence to it. It's going to be a lifelong challenge for this individual. But I guess from the group, I would love to hear, if they need to be treated for the rest of their life, what are the encouraging things you can share about, managing that treatment, and what does that look like, not just when you get started, but how does it evolve over the course of somebody's life?
Mm-hmm.
I'll go first because I have so many clients on medications for bipolar disorder. I have seen success, not to the level of our definition of success, so they can come off the meds and then they are in remission forever. Success means successfully treated, and that they have reached not only their baseline stability, but from there to embark on a path of reaching their greatest potential. One client, the one popping up in my head, within a month, 6 weeks, her bipolar type 2 diagnosis. So that's 6 weeks ago. We quickly just started treatment and she's back to baseline in 6 weeks, going through her own graduate program and looking forward to her future. She's very well educated about psychology already, and so she didn't have a lot of struggle about accepting the diagnosis. As a matter of fact, she's the one that looked up some symptoms and then told me, I think I might have it. And then lo and behold, I was like, wow, I think you do. And that was the best case scenario. Somebody comes and they want the treatment and then they get it. So seeing the potential that there is something that works for everybody. I just want to mention on a biological level, this is not even about not even including God yet, okay? So, but you include God and there's endless possibilities, but not even including God, just as a medical doctor, we say there is hope and there is treatment. And the problem is if you just don't get it, if you don't get the treatment, if you don't stay consistent on it, right? And it's a choice to be made. So we are here to provide, the best care possible. And in America, all of the mood stabilizers are available, right? Some more expensive than others. And they're still coming out with more and more, and even other alternative treatments. So my encouragement is definitely treatable, it's definitely recoverable. I cannot ever promise that it's definitely to the point where you can come off the medication, and only God knows that, if that's his plan. I would never say when. So that's why it's so worth it.
Dr. Lisa, you want to give words of encouragement?
I agree. And again, I think the more consistent our people that are struggling with bipolar can be, the more joy they will experience. And I think so. going back to the like medication non-compliance, I think it's also useful as therapists to talk to our clients about what are the possibilities if I can continue to stabilize, like what is there for me, like, and that is so exciting to like explore and identify with our loved ones or our clients, whoever it might be.
Mhm. Sometimes or oftentimes in our sessions and working with the patients, particularly bipolar disorder patients, it's sometimes very, very hard. Oftentimes very, very hard to say, or whatever the word that I can encourage them, right? So either answer this or answer that, wanted to give them hope. But still, it is a medical condition, but we don't know why all these things are happening and why particularly my patients are going through this, right? So when they are asking, why am I have to go through this, going through this? Sometimes we don't know why God allow all these conditions to me, don't know. Still, we as a clinicians, humbly, we will say that we don't know many of them, that we don't know the exact answer. But one thing that what we all know as a believers, whether we feel in a certain way or not, that we know for sure that God is there for us. Just because we don't know the answer, just because I'm going through that turbulence, doesn't mean that God doesn't love me. There's no evidence, but there's more evidence in the Bible that God still loves me, be with me, will be with me. And he has a greater plan for me. So rather than that, focusing on why and then unanswered the questions of all these conditions, we'll focus on the already given answer that Jesus is finished on the cross and he loves us. His love is greater than all those unanswered questions that we have, because there is a greater answer that is already given to us. So that will be my hope.
Amen.
There will be my hope. Still, I have, as an individual, there's just so many things is unanswered. I don't know why. I still have no answer. I think I share with you, or especially people who are here, I still don't know why my brother has to be sick and had a medical surgery and an incident. Is still a brain damaged and never be get better, right? I don't know. But one thing that I know, the given answer is God loves our family and myself. And that is my hope. And then eventually, I know that will be answered when I see Jesus.
Amen.
Amen. And that is an excellent way to wrap up our discussion. Thank you so much to Dr. Esther, Dr. Mejan for joining the panel, and Dr. Alyssa for being on the panel, and also that wonderful presentation. Thank you to everybody who joined and who was watching this video. I must say it was a real pleasure for me. Some of you may know this, but my mother has bipolar disorder. And so this is a topic very close to my heart. And if there is need for encouragement, is that as she got older and she's retired now, that she no longer needs to take medication. And she is doing just fine. And I would actually argue now that she's older and not on the medication and she's mellowed out of it, we have a much better relationship. It's been quite a blessing. And so there is hope and there is an encouragement. Our final, onto housekeeping stuff, our final Anchor of Hope this year is going to be November 12th. Topic will be forthcoming. Thank you again, all of you, for joining us this morning. And if you're joining us for the first time, we typically meet once a month on the second Saturday at 10 a.m. As I mentioned, the last one will be November 12th. We will not have a December session, I believe, this year. And if you enjoyed what you learned today, please feel free to share with your family members, friends, coworkers, anyone who can benefit from this topic. You can find recordings of all of our gatherings on YouTube under Oak Health Foundation, Anchor of Hope. And you can also go to our website, www.oakhealthfoundation.org or www.oak, F as in Frank, H as in happy.org. And with that, thank you all again. I hope y'all have a wonderful rest of your weekend, rest of your year, and we'll see y'all next time.